you and then I'll hand over the session to
Sure.
Dr. Vaidya.
Sounds good.
Yeah.
So now we are on live, so we are good to go.
Okay.
Yes.
Good afternoon, doctors. Welcome to this webinar on the role of oseltamivir in flu management. We have moderator Dr. Prakash Vaidya sir and speaker Dr. Mukesh Sanklecha sir. Welcome Dr. Vaidya. Welcome Dr. Sanklecha. This webinar is brought to you by Hetero Healthcare. Hetero Healthcare is an innovative pharmaceutical company and our journey began in 1993. Hetero Healthcare has 30 years of excellence and 36 state-of-art manufacturing facilities. 300 plus products in portfolio and presence in 126 plus countries. Hetero Healthcare has 21,000 employees globally and is the largest closely held pharmaceutical company in India. Hetero Healthcare is among the largest manufacturers of ARV, APIs and FDFs in the world and has Asia's largest API manufacturing facility at SEZ Complex, Visakhapatnam, Andhra Pradesh. Hetero Healthcare is 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties, pioneering in quality and innovation, and has the distinction of bringing 4 biosimilar products to market within 5 years of initiation. They are darbepoetin alpha, rituximab, bevacizumab, and adalimumab. During COVID-19 pandemic era, Hetero Healthcare, the pioneers in antivirals, offered oseltamivir, favipiravir, and remdesivir to the patients, because of which, in August 2020, Hetero Healthcare received an award of Pharma Excellence for COVID drugs. Today's webinar, role of oseltamivir in flu management. As I said, we have Dr. Prakash Vaidya and Dr. Mukesh Sanklecha with us. Dr. Prakash Vaidya sir is MD/DCH with diploma in pediatric sleep medicine from GCI, University of Colorado. Sir is attached to Fortis Hospital, Mumbai and Child Health Clinic, Mumbai, with senior pediatrician and special interest in pediatric immunology. Dr. Vaidya is joint national convener, asthma training module, revision 21-22, co-convener and writing committee member of Under 5 Visas module of IAP, writing committee member of Writing Antimicrobial Responsibility module of IAP, national trainer of for IAP and TB module, NRC cuff module, etc. Many presentations at faculty at IAP and other platforms. Sir is past president of IAP Thane branch and has 5 index publication and 1 textbook chapter. Welcome, Dr. Vaidya. Dr. Mukesh Sanklecha sir is consultant pediatrician, attached to Bombay Hospital Institute of Medical Science, Mumbai, Safi Hospital, Mumbai, and has been in practice for past 30 years. So the passions of Dr. Mukesh Sanklecha include pediatric allergies, pediatric asthma, pediatric infectious disease, and teaching. Sir has more than 45 publications in indexed Indian and international journals and has been a faculty in large number of national and international conferences. Dr. Mukesh has been a guide for MD Pediatrics for past several years. Once again, a warm welcome, Dr. Mukesh. And I hand over the section, Dr. Vaidya. Sir, I'll stop sharing and over to you.
Thank you, Dr. Prashant, for those kind words of introduction. And without further delay, I'll just share my presentation.
Yes, sir.
Is my screen visible?
Yes, sir. Yes, sir. Clearly.
Yeah. Okay. So good afternoon, everybody, and thanks for the people who have tuned into this. The topic is role of oseltamivir in flu management, and with me to have a lively discussion is Dr. Mukesh Sanklecha. So before we start the discussion, please bear with me while I just give you a few foundation facts, just to revise the ground on which we are going to discuss. So there are 3 things that I wanted to discuss. One is the virus, the clinical picture of flu, and something about the antiviral, that is oseltamivir. So we all know that flu is widespread, not necessarily today, but it is really widespread most of the year in our country, more so with peaks in the monsoon season. Across the world, there are 1 billion annual clinical cases, 3 to 5 million cases of severe illness, estimated to have 300,000 to 650,000 deaths per year. And regrettably, 99% of these deaths are in children under 5 years of age, especially so in low-income and developing countries. Something about the virus that causes this kind of widespread problem. The virus is a single-stranded RNA virus belonging to the Orthomyxoviridae family of viruses. There are 4 types of viruses, A, B, C, and D. Type A and B cause annual epidemics. Type A especially is known to cause pandemics. Type C, less common disease. Type D is only in cattle. So we are concerned with mainly type A and type B. So influenza A viruses are the ones that we commonly see, naturally able to infect a large range of animal species, including humans, swine, birds, seals, and horses. All these are the animals where there is reassortment occurring and more strains get released. Further, it is classified into subtypes as per the combination of proteins on the surface. And we know that on the surface, there are two main proteins which classify this virus. One is neuraminidase, NA, and the other is hemagglutinin. So these are the two large glycoproteins on the outside of the viral particles. HA is a lectin that allows binding of the virus to the target cells and entry of the virus genome into the target cell, while neuraminidase is involved in the release of the progeny virus from the infected cells by cleaving the sugars that bind these particles. So these are the two proteins that are targets for antiviral drugs. They are also antigens to which antibodies can be raised. Now, among A and B is not classified into subtypes, but there are two lineages. Now, rather, there were two lineages in circulation. One was B. Yamagata and the other is B. Victoria. But in the last few years, B. Yamagata has practically disappeared. And so WHO has recommended removing the B. Yamagata lineage from the influenza vaccine. That's how it has become trivalent from quadrivalent. So we are today dealing with three flu viruses, H1N1 type A, sub AH3N2, and B. Victoria. Indian data also says the same thing. This was a study from Haryana in 2025, which reflected the same thing. Now, this is a very interesting graph, which is coming from the influenza laboratory surveillance from the WHO, the global influenza surveillance system. This is from India. And if you notice, see the large number of flu cases. Now, in spite of the fact that we have very poor reporting, the cases are still very largely there in number. We had a peak between July and October. That was the flu epidemic in monsoon. But now in this season, the cases have started coming down, but there's a slight rise in mid-Jan. The other thing that this graph shows you is the type. If you notice, the light blue one is the H1 and the dark blue one, this one is H1N1. So H1N1 was predominant in the monsoon. Now it has come down and it is replaced by type B Victoria. So today the cases that we are seeing in the last, actually since late October, are majority are type B and not type A. Not that it makes a difference to the management, but this is just to understand the epidemiology. This is the record from the Indian data, but I'll just tell you one interesting thing is that the number of cases reported in Maharashtra, 392 and 3 deaths. Very, 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 very underestimated reporting, because there is no reporting, poor reporting in our country, and the data really does not reflect the ground reality in any which way. Now, a little bit about the symptoms. You all know that symptoms begin 1 to 4 days after infection, last around a week. And the common symptoms are like any other virus: fever, headache, myalgia, cough, rhinitis, etc. Ocular symptoms. Basically, it's a severe type of cold where you get central symptoms like headache, nasopharyngeal symptoms, systemic symptoms like high-grade fever, coughing, vomiting, sometimes diarrhea, sometimes joint involvement, and extreme tiredness. So it's really a milder respiratory illness. A cold is a milder version of a flu, or a flu is a severe version of a cold. But severity can be subjective and inconsistent. Now, a last bit of foundation facts on antiviral drugs. Initially, we had adamantine drugs like amantadine and rimantadine. These were adamantine drugs. These are also called M2 inhibitors. These are history now, no longer used. What is used today are neuraminidase inhibitors, which prevent the release of virus from the host cell and are active against A and B viruses. Plus, we have other drugs which sometimes are used. One is favipiravir and the other is baloxavir. Now, favipiravir is available in our country. Baloxavir is not so readily available. It's not actually licensed in India. So what are the antivirals available in our country? It's mainly oral oseltamivir, IV peramivir, inhaled zanimivir. These are all neuraminidase inhibitors. Inhaled zanimivir is available only as rotacaps in some places. Baloxavir is not approved in India. So our focus for flu management is really on oseltamivir, the most widely studied and available. So it was first approved for medical use in 1999 and it is available by mouth. It is still very useful. Selective inhibitor of neuraminidase enzyme, which prevents influenza virus replication and spread of infection. So this is what it does. It prevents the new virions from being released into the circulation, and therefore it halts the spread of the virus within the human body. With this foundation facts, let's go on to a case-based discussion. And I invite Dr. Mukesh to please join me as I go into the case-based scenarios. So Mukesh, can you see my slides?
Yes, I can.
Yeah. So let's start with a case that you and I see very commonly. It's a 2-year-old boy with high-grade fever, cough, cold. Initially, the child was active interfebrile, but on day 3, he has become lethargic and there is some dehydration. This is clinically ILI, an influenza-like illness. This child we had to admit because of lethargy, poor intake, and dehydration. So, Mukesh, when you see such a child, what are the DDs that go through your mind? Is it only flu or something else?
Can you go back to the first slide, Prakash?
Yes.
Yeah, so this child has high-grade fever, cough, cold, which tells you that he has currently an upper respiratory infection involving the mucosa. In a small child, the commonest etiology is viral. For you to clinically differentiate is usually difficult, but so it could be RSV, could be adeno, could be human metaneuro, of course, can be influenza, parainfluenza. So, Prakash, our assessment is based on the currently prevailing epidemiology.
Absolutely. I think we have to take into account the epidemiology in our area to really come to a shortlist. And what to put on the top of the shortlist depends on the prevailing epidemiology. Absolutely. Would you think of dengue here, Mukesh, as one of the possibilities?
So traditionally, we have always taught that dengue comes with predominantly non-respiratory symptoms: high fever, body ache, malaise, poor oral intake, vomiting. But in addition, occasionally, one of the presenting symptoms may be an upper respiratory tract involvement, though usually unusual. So I would not consider dengue as one of our leading differential diagnoses in a patient who comes with
depends on the area where you
respiratory symptoms.
We have a lot of dengue, and sometimes you do get a little sore throat, some cough, and dengue can come like this. So dengue does cross my mind in the first 1 or 2 days, especially when I don't have a very, very catarrhal illness, which tells me that, okay, this is flu or a virus.
Fair enough.
Okay. So what is severe influenza, Mukesh? How do you distinguish severe from non-severe flu? And
So
what are the red flag signs?
Yeah, so it's important to differentiate the two for several reasons. Number one, whether we should hospitalize the child and whether to put him in a room or in the ICU, or we can treat him on an OPD basis. Number two, whether to empirically treat him with A, antibiotics or B, antivirals. So it's very critical for you to classify the illness as moderate or severe versus mild. So you have a child who's looking unwell, whose vital parameters are impaired. His saturation is low, he's tachypnic, his respiratory rates are fast, his heart rate is very fast, his oral intake is poor, his urine output has gone down, he's persistently vomiting. So basically, it's a sick child who warrants either hospitalization or to go into the ICU.
So absence of these signs is non-severe, presence of these signs is severe. So people also, the definition also includes anyone with a novel influenza, something that we don't normally see, and there the mortality rates may be very high. So those with unknown risk for severe disease should also be considered severe, but this is what it is. And I think as Mukesh rightly said, the decision, the treatment may be the same, but whether it's in the ICU or whether it's in the ward or whether it's in the OPD depends on the criteria. So let's take one more case. Now, this child, Mukesh, would you send a nasopharyngeal swab for influenza, or will you empirically put the child on oseltamivir?
So now that you've hospitalized this child, of course, your indication for hospitalization was poor oral intake and a little dehydrated child. So this child goes into the hospital not based on etiology, but based on severity. So your call to treat this child empirically with oseltamivir would be based on, again, Prakash, the epidemiology. If
Yes.
currently I'm seeing very little influenza or A or B in the community, and this child gets hospitalized, my empiric assessment of etiology would put influenza much lower down. In direct contrast, as you put up some very nice data, if it was just monsoon where we're seeing a huge surge of influenza, in that setup, I would definitely start oseltamivir empirically.
So really it depends on the season. Current season, as you rightly said, flu has come down, and whatever swabs I have sent with suspected flu and those that have come positive have been mostly influenza B and not A. Of course, that doesn't change the
Yeah,
decision for
Prakash.
oseltamivir.
Yeah.
But as you rightly said, we are less likely now to empirically start as opposed to what we did 4 months back or 3 months back.
One more comment, Prakash.
Hello?
If this same child
Yeah,
is
yeah,
really
yeah.
bad, if this same child is really bad, can you hear me? Yeah.
Yes, yes.
So,
Of course.
Prakash, if this same child is really bad, he is having desaturation, he's going on the ventilator, and then the margin for error is very, very small, then I would empirically start oseltamivir pending investigations.
I think that makes a lot of sense because you have the only antiviral that works. So you take a chance that, okay, this may be flu, and we will pull out all stops, and one of the stops is definitely going to be oseltamivir. Now, let's take one more case, Mukesh. I had 18 months old child, Slok, who had past history of a typical febrile seizure. He had history of 2 days of fever, and he had one more febrile seizure at home, active in the clinic. So because he was active, we did not admit him, sent him home on symptomatic treatment. But his intermittent high-grade fever continues, though he remains active interfebrile. Now he gets one more short-lasting episode, and this time we admit him. Now, in this child, in today's scenario, yes, we admitted him for repeated seizures. Would you like to treat his presumed viral infection with oseltamivir in this current scenario?
Prakash, as you rightly said, the indication was for hospitalization was another febrile seizure and not actually a respiratory presentation. So I would not give oseltamivir to this child empirically. I would wait pending investigations.
Absolutely. So in a flu season, I would not wait. In a non-flu season, in a non-critical child, in today's scenario, I would wait. I think that sums it up. In a flu season, of course, your epidemiology is completely different, and there you know that the chances of hitting the target with oseltamivir is very much higher. So this child's influenza A was detected, but not H3N2, and anyway, he was treated. Now, Mukesh, if the same patient came to you, but he was active when you saw, and intake was not normal, and he was passing a good amount of urine, and okay, he had only one seizure in the past, and you decide to treat him on OPD basis, would you, in which scenarios will you give oseltamivir upfront to an OPD patient like
Okay,
this?
so if this child is clinically a mild presentation, mild respiratory presentation, then per se for the child itself, I would not give oseltamivir. However, if this child is immunocompromised by himself,
Yes.
he's with a congenital heart disease with left to right shunt, or he's on corticosteroids, or he's on a anti-malignancy drug, and he's at high risk for severe influenza in view of his or a primary immunodeficiency, secondary immunodeficiency. So he's at high risk for severe influenza based on his immune status. Then I would give him oseltamivir because his own immunity is compromised. The other indication would be if there is a high risk contact in his house who has potential for severe influenza. That would
Yes.
include maybe a child who's below 6 months, or an adult above 60, 65, or somebody who has chronic renal failure in the house, or again, somebody who's immunocompromised. So then, not for his sake, but for his contacts, high risk sake, I would probably initiate empiric oseltamivir on an OPD basis.
So that's a point well taken, Mukesh. It is not only that the epidemiology does matter when you treat a child upfront, but remember those who are high risk children, as Mukesh said, those who are immunocompromised, and those if they get flu will get a very bad flu, severe flu. Those we really treat upfront. Also, children with high risk contacts, because you don't want, the child may not need it for himself, but the high risk contact who is immunocompromised or very elderly patient, they may get infected and the problem may occur to them. So this is a situation where you will consider starting oseltamivir upfront. So which are the high risk patients for influenza complications? This is a chart from UpToDate, and I think Mukesh has really told you most of them. Chronic lung disease, CVS, kidney, hepatic, metabolic, even neurological and neurodevelopmental conditions like CP and epilepsy are sometimes included as per this chart in UpToDate. Extreme obesity, curiously, a person with a very high BMI above 95th percentile and immunosuppressed. So these are all children where you will consider upfront covering so that they do not get a severe infection in future. So, Mukesh, I'm sure, I mean, we have decided when do we give oseltamivir, and we have all put epidemiology on top and other things also. But have you ever used oseltamivir with a non-respiratory presentation? Let's say a child comes with diarrhea and vomiting. Would you then consider flu and cover him with oseltamivir in that scenario?
No, actually, I would not, Prakash.
You
Unless the child is really sick in the ICU,
would.
so pending investigations, I would. But a stable child who comes with diarrhea or vomiting or fever without focus, I would initially not initiate empiric oseltamivir, even if he's hospitalized but not in the ICU.
So diarrhea and vomiting is mentioned as a symptomatology, but I don't think it is mentioned as the only symptomatology. These children are going to have respiratory problem or the other, which points out
Right.
to maybe a virus that is non-enteric alone. So I think
Correct.
that's what you say. Now, in your practice, do you always give flu swab, do a flu swab before and after therapy? And what do you do if the swab comes negative?
Okay. First thing is, after therapy, there's no question of testing. So let's look at before
Correct.
therapy.
Correct.
So before, that was the easier answer. So I finished it off first.
Yeah.
So before initiating oseltamivir, in office practice, if I have a high flu season or I have a high risk contact in the family, I would initiate oseltamivir without confirming or ruling out. So I would not do a flu swab in a patient who comes to the OPD and I initiate oseltamivir on an outpatient basis. However, in a hospitalized patient, I would, in a high risk, in a high endemic situation, I would do both. Initiate oseltamivir and send for testing.
Yes.
In a low endemic situation, I would send for testing but not start oseltamivir.
Fair enough. So, and usually we do not start with, we do not start in OPD basis. We usually don't send swabs because of the cost issue as well. And the recommendations also tell us don't send swab on OPD basis. But when the swab comes negative, now there is a clear indication that you should stop the treatment. So I think there again, you have to see the clinical condition of the child, weigh the odds, because usually the positive predictive value of the swab is excellent, and so is the negative predictive value. So I think if it's a negative swab, we are reasonably sure that there is no flu in the picture. So I think one has to take a call based on the scenario. So what is the choice of antiviral therapy for children with suspected or confirmed influenza? I'm just sharing a table from UpToDate again. So they are always saying that the agent is oral oseltamivir for hospitalized children with severe problems and progressive clinical deterioration. What about children with non-severe illness? 2 weeks to 2 weeks through 4 years, oseltamivir. 5 to 6 years, oseltamivir. Baloxavir, where it's available, it's not available in India. And age above 7 years, oseltamivir, you may consider inhaled zanimivir, but it's not easily available to us. So for us, our drug of choice is oseltamivir across the entire spectrum of children. And children with non-severe illness agents, the most studied is oseltamivir. Now, the dose is to be given twice a day for 5 days, and we are aware that the dose, I'll share with you a dose table for revision soon. But before that, let me talk of another case. This is a child whose mother is breastfeeding, and this is a 6 weeks old baby. Who is your patient? The mother has moderate influenza symptoms, and her physician wants to put her on oseltamivir. So she calls you, her pediatrician, doc, is it safe for my baby if I take oseltamivir? So, Mukesh, how would you handle this answer?
I think over the past several years, we have realized that oseltamivir has an excellent safety profile. And so basically the concern is, if the oseltamivir crosses in the breast milk to the baby, would there be any potential for harm? Well, the answer is no. Though it has some hepatic and renal side effects, they're very minimal. It may cause gastritis and GER, but by and large, I think, Prakash, we have realized over the
Yes,
usage of oseltamivir over the past several years, it's an excellent drug, almost totally devoid of side effects. So actually, there's no contraindication for use. In fact, we need to reinforce to the mother that it must be used, because the contact of the mother, which is a 6-week-old baby, is at high risk for severe influenza.
absolutely. I think that is the emphasis, that we should encourage the mother to take oseltamivir. It will protect the baby as well. And but does the baby need prophylaxis in your opinion? It's a
Actually,
6-week-old baby.
it's a 6-week-old baby, and
Yeah.
it's at high risk for severe influenza. So yes, the answer is yes, this baby does need prophylaxis. Now, whether you would give prophylaxis or you would wait for the first symptoms to start before you start treatment for influenza is a moot call. But I think, Prakash, I would give prophylaxis to this child.
Okay. So
Though, if you look at guidelines,
yes.
yeah, go ahead, Prakash.
So this is the guidelines from up to date. Now, what they are saying is infants below 3 months, prophylaxis is not recommended except in critical situations. 3 to 8 months, it is 3 milligram per kilogram orally, and 9 to 11 months, 3.5 once daily. So they are recommending actually prophylaxis for older infants, but not
Correct.
below 3 months, because they are probably worried about the adverse effects. Interestingly, for preterm infants below 28 weeks, they say almost up to 8 months, they say prophylaxis is not recommended except in critical situations. So in a preterm, you're much less likely to go for prophylaxis up to 40 weeks to 8 months. So a baby who is 28 weeks, the question doesn't arise. But even a baby who is preterm and up to 8 months, they say that they do not want to give prophylaxis. But I think you have to take the call depending on the situation. And chronologic age 9 months to 1 month, up to 1 month, definitely prophylaxis is required. So the younger child, yes, but very young children, prophylaxis not is guarded, because the side effects are maybe there, and you may not want to give prophylaxis except in a critical situation. A little confusing, but I think that's the way it stands today. What do you say, Mukesh?
Fair enough.
Yeah.
Fair enough, I think. So we keep a 3-month cutoff as age for prophylaxis, below which we would not use it and above which we would use it.
I think
Though
is very judicious in the use
yeah,
there.
though, if you're using it as treatment for preterm children, I don't see why a 6-week-old would get harmed by
So
oseltamivir. But yes,
don't
Prakash,
use it casually. Just weigh your odds.
correct,
If the child looks
correct.
very sick child, yeah, you will still start. And I think most of us are very confident about oseltamivir, having used it for such a long time.
Right.
I've hardly, as you rightly
Correct.
said, there are hardly any adverse effects which we encounter. Okay, so let's take one more case. This is a 11-year-old boy who came with fever, cough, vomiting, altered sensorium, with clinical suspicion of encephalitis. And he was admitted elsewhere. X-ray showed raisins of on the right side. He was intubated in your emergency room, shifted to PICU. A CSF was done. CSF was normal, and he was started on IV antibiotics, IV antiviral, etc. The labs were not very suggestive. It was showing kind of a little high. I mean, the platelets had gone down a little, but otherwise they were fairly normal. And the nasopharyngeal PCR detected influenza, but the CSF meningitis panel was negative. Could you interpret these reports and tell me what to do, Mukesh, here?
Yeah, first of all, I think what you've said is IV antibiotics, IV antivirals. So
Yes,
he
yes.
was given acyclovir,
Yeah.
not any other. Okay,
Yeah.
correct.
We don't
Yeah,
unfortunately
so
have access to.
absolutely.
Yeah.
When we have encephalitis, that is our empiric initial coverage for a serious child, an
Yes.
antibiotic, antiviral, and in high seasons, even antimalarials. Now, so this child has got a nasopharyngeal multiplex PCR showing influenza. So obviously this child has active influenza. Now, the CSF panel has come negative. Does that mean that the child does not have CNS involvement with the virus? Well, Prakash, the answer is no, because this panel does not test for
It is such a
influenza.
pity that the biofire
So,
that we get in our country is
I know.
absolute in it is not, it does not detect influenza, it does not detect JE, and it does not detect common viruses like dengue.
Dengue,
So
correct.
yeah, it does not detect. So influenza will not be detected in the CSF. Yet, as Mukesh said, the presence of influenza in the multiplex PCR in the nasopharynx gives us adequate reason to say that this is probably influenza encephalitis. So neurologist reviewed the child, opined as viral, continued to have fever spikes, and the child also had acute kidney injury, which is also known with flu, by the way. EEG was normal, MRI brain was normal. Then he also developed aspiration pneumonia. Now my question is, Mukesh, this child has come to you on day 3, day 4, transferred from somewhere else, critically ill child who has not been covered with oseltamivir. You have detected now in the nasopharynx. Is it kind of worth giving oseltamivir to this child at this point of time?
I understand, Prakash, from where this question is coming, because
Mhm.
we all know that oseltamivir works best in the first 48 hours. So then is it that we don't use it after that? Well, the answer is no. Even after that, if the patient's symptoms are severe enough, like this child was, we have to give him benefit of doubt and give him oseltamivir, because we have the virus in the nasopharynx. We have a specific antiviral against it. So I would give it. Whether it benefits or not is a moot point. In direct contrast, if this patient was improving already by the time he came to me, then I would not initiate oseltamivir. But this child, I would give it.
But the take home message here is that though they say it has to be given in 48 hours after symptom onset, the point is that it is never too late to give it to a critical patient, because for whatever good that may ensue by giving it at that point of time. And
Absolutely.
also those with progressive disease, serious
Hmm.
complications, you wonder whether this could be flu. If it crosses your mind, possibly it is worth covering, because at least you're treating what is treatable. So this is the WHO algorithm, which I thought I'll share with you. Suspected or confirmed influenza. If severe, which we had already defined what is severe, it requires hospital care. If it is yes, give oseltamivir 75 milligram twice daily for 5 days in adults. In kids, I'll come to the chart. We all know it is 3 milligram per kilogram per dose in a younger child. Is the patient at high risk of progression into severe illness? You still give antiviral. WHO recommends baloxavir, but for us it is going to be oseltamivir. And if there is no risk factor, then no antiviral. Now, what are the risk factors? Immunocompromise, chronic disease, age more than 65, neurological or respiratory involved. I mean, chronic disease of CVS,
Hmm.
CNS, or RS. So, basically, the WHO says that give prophylaxis for zoonotic influenza, give it for antiviral in within 48 hours of exposure. If the defining criteria is the person is at risk of severe illness with multiple risk factors, immunocompromised, or age. Now, here for extremely high risk, the age defined is 85 years or over, or a very young
Oh,
child with multiple risk factors. Yeah. So, so prophylaxis is not something the WHO actually emphasizes. There are very selected patients who will go for prophylaxis. So just to revise the dose of oseltamivir for a
hmm.
quick reference, I'm sure all of us have such charts handy. Adults and dose over 13 years, more than 40 kg, 75 mg BD for 5 days is the dose of oral. Children from 1 to 13 years, it is 30, 45, 60, 75. But children under 1 year, it is 3 milligram per kilogram twice a day for 5 days. Otherwise, approximation is the of doses is what is done. So any child between 10 to 15 kg, 30, and so on and so forth. I think we can all keep this chart for ready perusal. And for prophylaxis, it is the same dose as this, except that it is once a day, and the duration is, instead of 5 days, it is 10 days. Okay, let's take one more case, Mukesh. I have this
Yeah.
6-year-old boy with an influenza-like illness, and it is the flu season. This is a case which was reported sometime few months back. Let's say when the monsoon was still not gone, and you propose starting oseltamivir on day 3, day 4, or even today for that matter. You propose starting oseltamivir, but the mother protests that he has received flu vaccine, doctor. How can he get flu? What is your reaction and how will you treat this child?
So, Prakash, firstly, if he's a 6-year-old guy, if I'm starting on an OPD basis, I would not start oseltamivir. But I assume the indication is there. He has some contact or it's a severe illness. And Prakash and I have decided to start oseltamivir. Now, the fact that the child has received the flu vaccine, first of all, the efficacy of the vaccine is at best between 50 and 70%. So it's not 100% effective. So the
True.
child can still get flu despite the relevant strain being there. The
Yes.
second thing is that the relevant strain may not be there. He may be inflicted by a second strain of influenza in the same epidemic. So for reasons more than one, if you decide to start oseltamivir with the correct indication, getting a flu vaccine is not a reason not to give oseltamivir.
So flu vaccine administration is not a reason to deny oseltamivir if on merit you feel it is worth starting, right? So will you do flu
Absolutely.
swab here? As we said, on OPD basis, we don't do. But sometimes for the sake of parents who simply love lab reports, as most of us have, they simply love lab reports. So you do it. They said, often tell me, doctor, I don't mind the cost, but please do it. So we do it in that case. But usually it doesn't make a rational sense to do it. So in short, treatment should be initiated regardless of whether he received seasonal influenza. We are talking of the peak flu season. Treatment should not be delayed, awaiting the results of viral testing when influenza is known to be circulating in the community. And also, one more interesting thing is a positive test for influenza does not mean that no other virus is in the picture, or a positive test for another virus does not always exclude flu. And I'll give you a case to show you this. But before that, Mukesh, we have been using oseltamivir quite a lot. There must be some adverse reactions, I'm sure. Can you share your experience? And do you make it a point to give PPIs with oseltamivir as a lot of practicing doctors do?
Yeah, so Prakash, I think again, I see where it's coming from, because theoretically oseltamivir does lead to GER and GRD, and hence the question. But by and large, if a child has symptoms of reflux, he has vomiting, he's arching his back, or if an older child complains of retrosternal pain or something like burning, only then would you use a PPI. Otherwise, by itself, empirically misusing a PPI, as a lot of us have done in the past for various indications, is a strict no-no.
Absolutely agree with you. PPI you must respect and not just use right and left. It had its own adverse effects. So not as a
Absolutely.
must with all oseltamivir therapy. Yeah. What about the other adverse effect you have seen?
Actually, nothing, Prakash. Though when you look up literature, its
Yes.
potential for renal side effects and other things are there.
So in Japan, they found Japan is one country which uses a lot of oseltamivir, and they had found neuropsychiatric effects like delirium, hallucinations, confusion, etc. But now they were not sure at the end of the day whether the causality was the virus or the drug. So some of the adverse effects may be related to the influenza infection itself rather than the treatment. But at least in my practice, I'm sure, I don't know whether Mukesh you have seen, I have not come across, and I've used oseltamivir in a good number of cases, never seen these neuropsychiatric effects at all, and rarely seen even GERD. But yes, sometimes there is vomiting, and you may consider just giving an antacid at that point of time, right? So parents ask you, Mukesh, that a child with flu, when can I send him to school, a child with viral? And does oseltamivir shorten the time that the child stays at home? Because that would be a delight to the parents. What do you think?
So once you initiate oseltamivir, it does reduce viral shedding. So the child remains infective for much shorter a duration. But by and large, the risk for viral dissemination remains for 3 to 5 days. So I would recommend that the child does not go for several days.
Which they will
But
not listen to you.
yeah. So Prakash, as you rightly put down on that, the CDC recommends that 24 hours of no fever
Yes.
is a
Without
reasonably,
24 hours
yeah,
of no fever without antipyretics is your
correct,
criteria for the
correct.
child to go home. And as Mukesh said, if you're already given oseltamivir, the chances of the child infecting his next door neighbor is very, very low. So let's take one more case. I have this 10-year-old boy who presented on day 2 fever with rigors, headache, and no clear focus. And the child had some tonsillar crypts. And the total count was 13,100 with a CRP of 32. This child had come with the report actually. And in this case, when we, the resident doctor who was with me said that let's start an antibiotic. Now I said, no, these are tonsillar crypts. We are not going to start. And I didn't really feel the need. But it was the flu season and the parents were also keen. So we did do the flu PCR. And there we found that this child had influenza A detected. So my point is that there are times when you do a test, when you start the drug and you end up saving, avoiding giving unnecessary antibiotics in a child in the flu season where you may still get a tonsillar crypts, but you have to carefully distinguish it from a thing like a tonsillar follicles. So let's take another child, 6-year-old girl whom I had seen again in the flu season, 11-year-old girl, sorry. Fever since 2 days, high grade, not associated with chills or rigors. And the child had bronchospasm and came with breathlessness. She was admitted last month in a different nursing home with influenza A. This time she was very sick. She required HFNC. We gradually weaned her to face mask. We gave her antibiotics. Then we gave her oseltamivir, azithromycin, etc. Because we did not know the cause at that point of time. And she received nebulized beta 2. And this child also showed influenza B plus RSV. So it highlights two things. I think, Mukesh, you must have also seen a lot of cases like this. A, where the flu swab has been done more than once, and it's either once you show up A and once you show up B, and second time you may get B coexisting with another virus. Have you seen such reports, Mukesh? Hello? Hello?
Yeah, Prakash.
Yeah.
I think with the advent of multiplex PCR, this confusion is only becoming worse. So
Yes.
we are seeing these kind of multiple viruses, and then we are scratching our head as to what to do. Fortunately, there is only one antiviral available. So when influenza turns up, we treat that, and
Right.
the rest of the treatment is all supportive. So we are okay with it. I'm only worried if once 3-4 antivirals come up, one for RSV, one for adenovirus, and then if we have 2-3 viruses, what will we do?
What are we going to do? We're going to give polytherapy or what? So the moral of this story is that, yes, influenza A last month does not mean that the child can't get B this time, and you have to your index of suspicion remains the same. You treat it on merits. And the other thing is that influenza A and B with RSV, we have seen so many cases in the season. So luckily or otherwise, there is no treatment for RSV. So you're not in a dilemma. You still give oseltamivir, but I think the chances of co-infection is high. So even theoretically, if there were a drug available for RSV and the child was sick enough, my bet would be to give both the drugs.
Correct. Yes.
I have another child who is a 10-year-old Arjun with who is asthma. The child is on inhaled corticosteroids. This is the flu season. He has ILI symptoms. This child is, if he was obese, what would you do? Will you give oseltamivir upfront to this child, Mukesh?
So Prakash, I think your high risk population includes obesity.
Yes.
So otherwise, I would have probably not, but after the list that you've put up, it's interesting and it would widen my horizon. So maybe Prakash, if it's a high epidemic situation, I would give it. If it's a low epidemic where my chance of it being influenza is rather low, then I would not give it. But yes, upfront, based on obesity, high risk factor, I would give it.
So asthma, would you say, is a high risk factor?
So if it's a controlled asthma,
yes,
where there are not many or no exacerbations, then it's not a high risk factor. But if it is uncontrolled, then yes, Prakash.
Okay.
Then I would give it.
So now the child is seeing, you're seeing this child, and now after 2 days that give you the history that grandmother also had flu, and grandmother was ill and she tested influenza B positive. Now will you give Arjun oseltamivir?
Yeah. So Prakash, actually, I think this reinforces an important concept of taking a good history in a busy OPD. We should not just look at Arjun, but when Arjun came the first time, we should have checked whether there's a background of a high risk contact.
Correct.
So even if Arjun was not obese, now that you're telling me there is a grandmother whose who's there at home, I would have given Arjun oseltamivir the first time,
In order to
even if he
protect
was
the grandmother.
even if he was as slim and fit like you, even then.
So to protect the grandmother, you will cover Arjun.
Correct.
Interesting perspective. Yeah. So now let's talk of the relation between oseltamivir and antibiotics. Now, whenever there is viral infections or whenever there's an epidemic, we find that in India, which is actually we use, unfortunately, antibiotics are misused in a big way. They are even more misused when there are outbreaks of infections. So I think when you are able to diagnose flu and you're going to prove flu, probably the antibiotic stewardship is strengthened. So, but in a child with flu, with influenza, are there any situations, Mukesh, where you would like to use antibiotics along with oseltamivir?
Okay, so if your initial presentation is a severe illness, the child is desaturating, he has a patch on the lung, a clear lobar pneumonia, he's on the ventilator, there is neutrophil leukocytosis, your procalcitonin is very high, your CRP is dramatically elevated. So on presentation, if the child is very sick or there is some clue that it could be a bacterial infection, I would give antibiotics. Also, if it's not such a sick child but is not improving on oseltamivir, that is the time I would reconsider whether A, my diagnosis is correct, and B, there is a risk of a superadded infection.
Yeah, especially if the child is improving and now starts deteriorating and you start
Okay,
investigating and
correct.
there's a rise in CRP or there is a patch
Yes.
developing, surely you will think
Correct.
it's a secondary infection and possibly you will give, especially with persistent fever, neutrophilia, etc. But empirical,
Sure.
no antibiotic. Just because the child is having fever, you give oseltamivir plus you give something else. That's not the way it is done. So
Absolutely.
unless there is evidence of concurrent infection. So does diagnosis help AMS, antimicrobial stewardship? There was a very large study from China with almost 12,000 people, and they found that antibiotic prescriptions were more frequent during periods of low uh, influenza virus activity than in peak season. So whenever influenza virus activity is there and you prove it, the antibiotic use does go down. So there is definitely a need for diagnosing influenza, maybe doing swabs. And once you treat with oseltamivir, many times you find that you have been able to do antimicrobial stewardship and the patient doesn't unnecessarily get antimicrobials. So in periods of low influenza, people start thinking more of bacterial, but in periods of high influenza, there is a stewardship. Now, let me put the
Interesting.
question on its head.
Hmm.
Do we need oseltamivir stewardship? Can we be guilty of overusing it sometimes?
Yeah, so Prakash, I think it's very much based on the season,
Yeah,
in a high incidence season, we may use it with a lower threshold and the risk of overusing it is there. And in direct contrast, in a low epidemiology setting, there is the risk of underutilizing it. It's like currently, when influenza is not on our radar, there is a chance that in occasional influenza, we may not give oseltamivir when it is indicated.
absolutely. I think you have put it absolutely succinctly. So when do you give prophylaxis? We have already done that. Do you give, let me ask a quick, quick rapid fire question because we are running out of time. So would you give it to a parent of an admitted child, oseltamivir?
If high risk.
Yeah. Grandparents of the discharged child, you discharge the child and
Again, if high risk, I assume they're above 65, so I would give it then.
and younger sibling of the influenza patient.
Again, if high risk, that's below 2 years and especially below 6 months,
And
but
if the
more than
child
3 months, as you rightly
high
said.
risk chemotherapy or uh,
Or correct.
or steroid
Absolutely. Yeah.
or some problem. Correct.
Perfect.
So post-exposure prophylaxis only for individuals who have a high risk of hospitalization if they contracted influenza, do not expand it to others. Now, one more interesting point before I conclude is I had a child with croup, and this child, we did a multiplex PCR and we found para-influenza. And seeing the word influenza, my resident doctor had already put the child on oseltamivir. What is your reaction to this?
Yes, so it doesn't cover para-influenza. It only covers influenza.
Yeah.
So
So the presence of
it's a
influenza in
wrong
the name.
prescription.
Yeah, let's not get it.
Yeah.
The oseltamivir has no effect on para-influenza. So let's understand that unlike in say in in typhoid, where you may have, a broader spectrum.
Typhoid, yes.
Yeah, but
Correct.
here para-influenza does
Good
not
one.
require oseltamivir. Right.
Yes.
So, Mukesh, what is the contraindication to oseltamivir on the basis of your experience in practice?
Virtually nothing unless you can't administer drug orally.
Yeah,
There's no real contraindication.
absolutely. So, if the patient has severe influenza and you can't give by enteric methods, like for example, you can't because of malabsorption or a GI bleed, you will have to wait till it stops, because peramavir may be an option, but I don't see it is easily available in our country. And remember, pregnancy is not a contraindication. There have been so many exposed outcomes, 1,000 in one study, that it is safe during pregnancy with no malformation nor fetal toxicity. Important to remember this. So pregnant women can be offered oseltamivir when the potential benefits of using the drug are more likely than the harm. Does oseltamivir interact with any vaccine, with the flu vaccine?
Not the killed vaccine, only the live
Not
vaccine, which
flu
you're
vaccine.
not using.
Yeah, we are not using the live vaccine, so there is no interaction with oseltamivir. Now, just to conclude and just to summarize, flu vaccine is now trivalent. It's something that we all should be aware. So, WHO has removed the second B from the quadrivalent flu vaccine, and today we are going to use henceforth, at least in the foreseeable future, only the trivalent vaccine. So it will be H1N1, H3N2, and B Victoria, B Yamagata has been dropped. I think that is something we all know. This is done with the interest of reducing the cost, as well as so that is what the WHO said. The cost will come down by removing one of the 4 components of the vaccine. So flu vaccine henceforth is going to be trivalent. So I think we have covered a lot of ground. If there are any questions,
Yes.
take it. To sum up, oseltamivir is currently the main anti-influenza drug available and approved. Very useful drug both in treatment and prophylaxis. Usage has to be timely and with proper indications. Remember, it is never too late to use when influenza is a possibility in critical patients, and we should not be using oseltamivir indiscriminately. With that, I thank you for your attention, and I'll stop screen sharing. We'll be happy to take any questions that may be there.
Sir, thank you very much. As usual, it was a lovely session with a lot of insights, especially the patient discussion. Thanks, Dr. Mukesh, for your inputs. Thank you. Thank all the doctors who took time and attended this webinar. Thanks IT team, marketing and sales team for your coordination. Thank you so much, sir. Wish you a very pleasant evening. Sankranticha
Thank you.
Shubhecha.
Thank you.
You and Dr.
Dr.
Mukesh.
Prashant, is there any
Thank you.
way
And we
some
can.
questions can be taken? I mean,
There are
in
no
future
questions,
or-
sir. But yes, I mean, we are always, I mean, it's there, the link is there. If any question comes, we'll always send it back to
always
you.
share it. All right.
Yes.
Okay, cool.
Thank you, sir.
Thank you. Thank you.
Okay, thank you.
Good day.